For the next presentation, I would like to invite the moderator of the session, Dr. Sushil Kumar Chopra, sir. Sir is one of the senior members from the fraternity. Sir is currently scientific director and embryologist at Unique Fertility Center from Ludhiana. He's the founder member and currently joint secretary for ACE Academy of Clinical Embryologists India. Sir, stage is all yours.
Good morning, everyone, to the second lecture of the morning session. And the next speaker is Dr. George Liperis, who is a very well-known personality and is a Deputy Scientific Director, Westmed Fertility Center, Australia. He's also a senior lecturer at the University of Sydney, and he's a ASHRAE certified clinical embryologist. He's also embryology, andrology, and genetic laboratory supervisor. His main research interests consist of the development of improved methods in assisted conception. Number of publications, including book chapters in quality control and control of variables in the IVF lab. Today, he'll be speaking on routine semen analysis. Should the WHO criteria for normal sperm be the driving force for selecting the fertilization method? Over to Dr. George Liperis.
Thank you, Dr. Sushil Chopra. Thank you, Ahera, for inviting me to give this presentation on this very special day. So I'll be talking about the routine semen analysis and whether the WHO criteria should be the driving force for the selection of fertilization method. I hope you can see my screen.
Yeah.
So during this lecture, in the next 20 minutes, I'm going to first give an overview of the male infertility and the WHO criteria. I'm going to then describe the differences between IVF and ICSI. And finally, describe whether the WHO criteria for normal sperm should decide and be the method of whether we decide the fertilization method. And I'm going to show that by a retrospective analysis of some data from our clinic. So we do know that infertility is a common, in many couples. Approximately 1 in 6 couples worldwide experience some sort of infertility during their reproductive lifespan. And we know that the current prevalence of infertility for at least a year is between 8 to 12% worldwide for women aged between 20 and 44. But how about men? There is about 20 to 30% of infertility cases explained by physiological causes in men, about 20 to 35% by physiological causes in women, and 25 to 40% because of an issue in both partners. So the relatively low efficiency of IVF can be partly due to the quality of the spermatozoa, including the poor quality ejaculates and testicular samples, as well as the high percentages of DNA fragmentation in the ejaculate. So in regards to male infertility, it's the single most common cause of infertility. And we know that up to 50% of couples are referred for infertility treatment and have a male component of the problem. And in the latest years, there has been an increase in cases referred due to improved techniques for treatment like single sperm freezing, open biopsies, etc. And there's a number of causes of male infertility ranging from poor semen quality, ejaculatory dysfunction, obstructive and non-obstructive azoospermia. So what about the WHO criteria? Semen quality is a measure of male fecundity in male fertility. And there is reference intervals for values of semen parameters from a fertile population. And that data could provide us with a prognosis of fertility or diagnosis of infertility. The WHO criteria have lower reference limits, and these are based on fifth centiles and provide a 95% confidence interval for semen characteristics in sperm, and they're widely used as a source of standard methodology for laboratories engaged in semen analysis. And this is the current WHO criteria. There is, the next edition is coming out very shortly. I think next week is the presentation. But in terms of the reference intervals, we see that the semen volume is about 1.5. That's the lower reference limit. 39 million per ejaculate total sperm numbers, out of which the concentration over 15 million per ml, of total motility 40%. Out of those, progressive motile should be over 32%, 58% of those vital, and sperm morphology consisting of 4% of normal sperm. However, there has been an evolution of the normal semen parameters values over the different WHO manual editions from 1980 to 2010. And a comparison of the reference values with previous editions shows a reduction in the majority of the reference values for normal sperm samples. And we can see just that from the previous to the current edition. Every single semen parameter that we use in terms of defining the quality of the sample has been reduced. The volume from 2 to 1.5, sperm concentration from 20 million to 15 million, sperm count approximately the same, progressive motility from 50 to 32%, vitality 58% to consider normal, and morphology from 15 to 4%. So does that mean that the sperm counts are declining? And there has been a numerous number of studies that indicate that there has been a declining sperm count population, starting from this study in the US, a global study published thereafter, European study, a study in France. However, in these earlier studies, the techniques were less developed and the results less reliable. And we know that the sperm levels can drop a long way without affecting most men's fertility. This is very important to consider. But most importantly, the duration of abstinence plays an important role. As we can see here, the total sperm count increases with the testicular volume based on the days of abstinence. So this is something that all of these studies need to take into account. Therefore, retrospective or short-lived studies cannot really provide substantial evidence to support declining sperm counts. Only prospective monitoring systems encompassing longer time periods and involving also semen quality as well as direct fertility measures, such as time to pregnancy, is representative populations could be considered. An example of this has been shown in Denmark, where the mean sperm concentration of 5,000 Danish army draftees from 1996 to 2010, so over a span of 14 years, has not shown any decline in the values of sperm. Another study here has shown that there is considerable differences between semen analysis, and a number of different analyses are required when evaluating semen parameters. So therefore, there has been an evolution of normal sperm parameters from the different WHO manual editions. Comparison of semen reference values with previous editions shows a reduction in the majority of reference values for normal sperm samples. But this WHO analysis, we have to take into consideration that is not based on universal analysis of all men. Even in the 6th edition that is about to be published in the forthcoming weeks, we have to know that only men from 12 countries have been included. And also having in mind the variance in the sperm parameters, how much weight should semen analysis be given for determination of the fertilization method? So why is it such a big deal? What method do we use? The trends over the last 15 years in ART shows that there has been a tremendous overuse of ICSI. And we can see here from 1997 all the way to 2011, how much more ICSI we have been doing and how much less IVF we have been doing. And we have already shown that this is not due to deteriorating semen values. We know that ICSI has no outcome benefits, and this is very important to consider, over conventional IVF when there is a non-male factor in infertility. Also, the number of oocytes retrieved by a woman has no value in the selection of the insemination procedure when there is no male factor in fertility. What is the rationale then? The rationale for using higher ICSI in non-male factor cases is based on a wrong assumption that ICSI is associated with a higher likelihood of fertilization and an increased number of available embryos. And we know that there is the first randomized control trial on the way at the moment, and this should put this to bed once and for all, comparing the effectiveness of ICSI versus conventional IVF in couples with non-male factor infertility. I'm waiting to see those results. But what are the risks when we're overusing ICSI? So the World ART figures show the unexplained differences in ICSI usage. And there's a number of studies that suggest that ART treatments, especially ICSI, may give rise to cognitive impairment. So some birth defects are more likely to occur with ICSI, like a number of epigenetic syndromes. And this may be due to the in vitro versus the in vivo selective mechanisms for sperm selection. They may be due to the physical damages occurring during ICSI, and also to point mutations resulting from physical and chemical stressors during the in vitro process. So therefore, should the WHO criteria for normal sperm be the driving force for fertilization method? I'm going to talk about now the experience gains from our current practice. So we know that the routine semen analysis provides useful information in regards to the sperm production by the testes, the sperm motility and viability, the patency of the male genital tract, the secretions of the accessory organs, and about ejaculation and emission. This information by semen analysis is useful for the initial evaluation of the infertile male. However, as far as the diagnosis of fertility and subfertility, semen analysis does not represent a definitive test of male fertility. Semen analysis can provide an indication for the presence of sperm and fertilization method, but the sample on the day might differ significantly. And this is what we need to base our decision making on, the sample on the day. So in terms of laboratory finding versus andrological diagnosis, there is a number of spontaneous pregnancies that have been reported in couples with severe male reproductive disorders. And we also know that there is a few cases of spontaneous pregnancies without treatment that have been described in cases of severe oligoasthenozoospermia of less than 1 million per ml and motility of less than 30%. Of course, that makes some members of the male population be extremely happy to hear. We also know that the sperm morphology has no influence on fertilization and pregnancy outcomes when conventional in vitro fertilization is used, based on this nice study that was published 3 years ago. And here we can see that even with sperm that had less than 4% normal morphology, we can see that there is no difference in any of the clinical and developmental parameters that were studied. So our hypothesis, we can hypothesize whether conventional IVF can be used for sperm samples of mild and moderate oligoasthenozoospermia as assessed on the day of fertilization by experienced embryologists with empirical assessment of morphology. So in those categories, we included mild oligoasthenozoospermic male between 1 and 5 million per ml of total motile sperm, and moderate oligoasthenozoospermic males between 5 and 20 million per ml of total motile sperm. So all the participants were consented patients undergoing IVF or ICSI at the Westmead Fertility Center between January 2018 and December 2019. And on our center, the embryologists make the final decision towards the fertilization method, as even when the patients have had several seminal fluid analysis, the semen samples on the day can significantly vary. The sperm ejaculates on the day were collected at the same day as oocyte retrieval by masturbation, and the following parameters were assessed as per WHO criteria: the volume, the concentration, and the motility. Sperm preparation was done by discontinuous density gradient centrifugation. We used 2 layers of 80 and 40%. And the majority of people in this audience will be familiar with the density gradient. And we have the lower phase at the 80%, the upper phase at 40%. We know that after 20 minutes of centrifugation in the gradient, viable motile spermatozoa will be gathered in the pellet. The interface will gather a number of non-motile sperm, and all the non-sperm cells will be caught up at above the upper phase. In quick summary, after the density gradient, we aspirate the pellets. Then we suspend in wash media followed by another 5 minutes centrifugation. And then after the wash, again, the pellet is aspirated, resuspended in another wash media, followed by another 5 minutes of centrifugation. And then the pellet is aspirated and resuspended in the stock sample of containing GIVF media, and that ranges between 0.1 and 1 ml depending on the sample. So the resuspended GIVF media was then loaded onto a hemocytometer, and the concentration was assessed. So this is the defining factor that decides for us the fertilization method. At this stage, samples with 1 or more million per ml concentration and more than 70% progressively motile sperm were used for conventional IVF, regardless of whether the semen analysis supported their use for IVF. So if any sample met these parameters during the study period, was used downstream for conventional IVF. So a minimum of 10 microliter and a maximum of 100 microliter were used for insemination. The insemination dish consisted of 1 ml of GIVF media, and up to 7 COCs, cumulus oocyte complexes, were added into the dish. We did open culture insemination at in a box incubator, purchased at 17 hours post-insemination. So what did our results show? So over the designated study period, we had 83 couples with at least 3 oocytes collected that had fertilization by conventional IVF from ejaculates that did not meet the WHO reference values for all of the 3 below categories. Density, so all of them had a density of less than 15 million per ml. All of them had a progressive motility of less than 32% and total motile count of less than 20 million per ml. So in general, the ejaculatory values were the following: average volume was 2.7, average total count of 27 million per ml, average total motile count 5.2 million, average density 9.9, and average progressive motility about 20%. So following the gradient centrifugation in the 2 wash steps, the mean volume of resuspended sperm was about 0.5 ml. The number of oocytes collected per average was 8 oocytes, and the number of mature oocytes at fertilization check was 7.2, so majority of the oocytes were mature. Fertilization rate was about 66%, and the fertilization rate per mature oocyte was 73.2%. So in order to have a comparison, during the study time frame in our center, fertilization rate per cycle and per mature oocyte for sperm ejaculates that met the WHO norms for patients that had at least 3 oocytes collected was 65%. So very similar to what we had in our study, and 72%, which is very similar to what we had in our study. So from the total numbers, we had 2 failed fertilization with an average of 5 oocytes collected from this cycle. And again, in a comparison during the equivalent time period of our study, the failed fertilization rate by conventional IVF for normal WHO sperm was about 1.8%, but there was no statistical difference. So about the same in terms of the failed FERT outcome. So what are the limitations of this study that I just presented? So these results represent the experience gained from our current practice and not a prospective control trial. The developmental potential of these embryos that originated downstream of this approach and the clinical outcomes were not explored further. And in conclusion, the sperm ejaculates with less than WHO reference values could be considered for conventional IVF, as these samples can still result in satisfactory fertilization outcome without increasing failed fertilization. And there are wider implications of this study. As we know, semen analyses are in general very poor markers of true male fertility. And although the reference values serve as decision criteria for clinical management, reduction of sperm motility or sperm count does not really unravel the underlying causes of the male infertility. In conclusion, the effective treatment requires evaluation of semen parameters on the day of fertilization, as the previous semen analyses do not always concur and not fully predict the post-preparation values. In other words, we don't know how the sample is going to look like on the day, and we don't know how the sample is going to also prepare on the day. And just because this is the World Embryology Day, I'm just going to show this video. Thank you very much for listening.
Thank you, George, for a wonderful talk. Now, any question and answers from the audience? Can you see your chat box?
So I'll be posting. There might be no questions for now. Sir, can you take one of few questions from your side, Sushil sir?
Hello?
Hello. Yeah. Can you hear me, sir?
Hello?
Rahul, there is one question
Ah.
on this. You just check it in this. Question is that can we use the other combination of density gradient other than 40 to 80%?
Absolutely. This depends on the practices that every center is applying. Of course, I wouldn't recommend just starting to use any random series of concentration gradients. It's all a matter of trialing your methods and seeing what kind of yield of mortal spermatozoa you get from your current practice, because everything depends not just on the amount of density gradient, but also the volume, on the materials that are being used, on the abilities of the embryologist to accurately define, on the type of the centrifuge, on the speed. So there's a number of parameters that can define the yield of motile spermatozoa that can go after the pellet. So not just looking at the density ranges. I know that other centers might use different levels of gradient, like 45 to 90 instead of 40 to 80. So some sort of ranges can be used, but ultimately it's a matter of with your current methodology, trying to establish what the experimental and parameters will give you the higher yield to be followed in your clinical practice.
Yeah. So thank you so much, Dr. George, for enlightening us with this wonderful talk of yours on semen analysis. Thank you, moderator, Dr. Sushil Kumar Chopra, sir.